Okay, today's lecture is pituitary disorder. So pituitary disorder, pituitary is an endocrine organ, right? So the pituitary disorder, okay, there is the hyper and pituitary disorder. It may be hyper or maybe hypo. Okay, so hyper is hyper or hypo. Okay, or maybe due to tumor effect. Mass effect means tumor effect. Okay. So hyper is excess hormone called hyper, deficiency is hypo. So excess pituitary hormone leads to clinical manifestation. This is called pituitary disorder. There may be causes that leads to increased pituitary hormone. There leads to increased pituitary hormone production, and this excess pituitary hormone affects on the organ and present clinical manifestation. Okay, hypopituitarism also same. When there is pituitary hormone, there are the causes that decrease, impair pituitary hormone production. So when there is pituitary in the blood, then it affects on the organ and it presents with clinical feature and complication. Mass effect also say mass effect means tumor effect. So the one you remember paraneoplastic syndrome. So this tumor it may produce more hormone, or maybe it compress the adjacent tissue and it leads to decreased hormone production. So tumor effect, there may be two effects. One is this pituitary, the tumor in the pituitary gland, it produces more hormone. This is called functioning pituitary adenoma, more hormone. Or this tumor compress the adjacent normal tissue, then the tissue, pituitary is an endocrine organ, right? It compresses the adjacent normal tissue. Then adjacent normal tissue means these are endocrine, or the one the pituitary, adjacent pituitary gland. So these pituitary gland cannot produce hormone. It leads to pituitary hormone deficiency. Okay, so functioning and non-functioning. Functioning means more hormone production. Non-functioning means pituitary hormone deficiency. Okay, causes of hyperpituitarism. So they are the causes that increase pituitary hormone production. So one is anterior pituitary, hyperplasia, adenoma, carcinoma. So adenoma, hyperplasia, when pituitary, hyperplasia, the one just recall general pathology. Adenoma, just now I explained, functioning adenoma. Functioning adenoma means it produces more hormone, okay, and then cancer. Pituitary is controlled by hypothalamus. So when there is the disease in hypothalamus disorder, there is more hormone production. Hypothalamus disorder, it stimulates more anterior pituitary to more hormone production. Okay, the third is paraneoplastic syndrome. Paraneoplastic syndrome means the tumor, non-pituitary tumor, then it produces hormone. So let's say like pituitary is a non-pituitary, the organ is, let's say, lung. Lung produce hormone. The hormone is the produce from the pituitary gland, like ACTH. So ACTH is produced from the anterior pituitary. But the lung cancer produce ACTH. This is called paraneoplastic syndrome. So hypothalamus, just recall physiology, the one that Dr. Asra already mentioned. TRH, thyrotrophin releasing hormone, corticotrophin releasing hormone, gonadotrophin releasing hormone, growth hormone releasing hormone, growth hormone inhibitory hormone, prolactin releasing factor, prolactin inhibitory hormone, okay, or dopamine. So the one, the hypothalamus, act on the anterior pituitary, act on the pituitary. So hypothalamus act on the anterior pituitary by blood vessel, so adenohypophysis. Okay, but the posterior pituitary, hypothalamus act on the posterior pituitary by neurohypophysis. So there is a differences between anterior pituitary hormone and posterior pituitary hormone. So anterior pituitary hormone, like hypothalamus, act on the anterior pituitary, and the anterior pituitary synthesize hormone. But the posterior pituitary, the hormone, oxytocin, the one is antidiuretic hormone, they are synthesized from the hypothalamus and stored in the posterior pituitary. Okay, so that's why when there is deficient, there is the disorder. Disorder is hypothalamus, not the posterior pituitary cause. Okay. So control of TSH secretion, negative feedback. So this one just recall physiology. So hypothalamus produce thyrotrophin releasing hormone, act on the anterior pituitary. So anterior pituitary release TSH, thyroid stimulating hormone. So this thyroid hormone, TSH act on the thyroid and it produce thyroid hormone. So there is a negative feedback, okay, on TSH, anterior pituitary. When there is excess thyroid hormone, there is a negative feedback on the anterior pituitary and hypothalamus. Okay, now we go to the hyperthyroidism. So hyperthyroidism and hypothyroidism. There is a primary hyperthyroidism and secondary hyperthyroidism. Primary means the pathology is in the thyroid. It is called primary. Okay, pathology. There is hyperthyroidism means there is excess thyroid hormone in the blood. Okay, so excess thyroid hormone may be due to primary cause or secondary cause. Primary cause means pathology is at the thyroid gland. Secondary cause is pathology is at the anterior pituitary or hypothalamus. So it means that there is thyroid hormone itself produce thyroid pathology is the thyroid gland. There is a thyroid adenoma, hyperplasia. It leads to excess thyroid hormone production. This is primary cause. Okay, there is and pathology is anterior pituitary. That's therefore anterior pituitary produce TSH. So this TSH act on the thyroid gland and it leads to excess thyroid hormone production. This is the secondary cause. This excess thyroid hormone production known as hyperthyroidism. It is due to secondary cause. Secondary cause may be due to anterior pituitary. Same as hypothalamus. Pathology is at the hypothalamus. So there is TRH, more TRH secretion. So this thyrotrophin releasing hormone act on the thyroid stimulating hormone. So act on the anterior pituitary. So anterior pituitary produce more TSH. So this TSH act on the thyroid and it produce excess thyroid hormone production. So this is the pathology is hypothalamus. So this is secondary cause. So whenever we discuss the primary, secondary mean primary is the one the thyroid itself is primary. Secondary is anterior pituitary cause or hypothalamus cause. Okay, this one you need to understand first. So abnormalities of TSH. So TSH secretion, thyroid as TSH secretion reduce, it leads to hypothyroidism. This hypothyroidism is secondary hypothyroidism. Anterior pituitary pathology, there is excess TSH secretion leads to hyperthyroidism. So this hyperthyroidism is secondary hyperthyroidism. Okay. Same as the hyperthyroid, the one we discussed in hyperthyroid lecture. Okay, so okay, ACTH, same as ACTH, adrenocorticotropic hormone. So hypothalamus produce corticotrophin releasing hormone CRH. So this CRH act on the anterior pituitary to produce ACTH. So this ACTH act on the adrenal cortex, produce corticosteroid. So as negative feedback as usual. Okay, so excess corticosteroid act on the anterior pituitary and act on the hypothalamus. Okay, the one just I explained hyper and primary and secondary. So excess corticosteroid is called hypercortisolism. Reduce ACTH deficiency is called hypocortisolism. So hypercortisolism, also known as Cushing disease. Okay, so Cushing disease is the excess ACTH is called Cushing disease. So in here, this excess ACTH deficiency is due to anterior pituitary cause. So this is secondary cause. Okay, secondary hyperthyroidism, and then secondary secondary hypercortisolism or secondary hypocortisolism. So the one that excess cortisol, corticosteroid, excess corticosteroid in the blood is called hypercortisolism. So primary cause is adrenal cortex cause, secondary cause is anterior pituitary or hypothalamus cause. Okay, another one here. Adrenal, you see here, adrenal cortex, corticosteroid, negative feedback, right? Corticosteroid, when there is excess corticosteroid, there is negative feedback on anterior pituitary and hypothalamus. Okay, we take a corticosteroid, the one, the oral corticosteroid, exogenous corticosteroid, the one, the drug. So when there is excess corticosteroid in the blood, as usual, when there is excess corticosteroid in the blood, it may be endogenous or exogenous. Endogenous means produced from adrenal cortex, or exogenous produced from the drug, okay, medicine. So whenever there is excess corticosteroid in the blood, then this corticosteroid have negative effect on anterior pituitary and hypothalamus. So so negative feedback means anterior effect on anterior pituitary. So anterior pituitary produce less ACTH. So this one less ACTH. So this one act on that. There is no effect on adrenal cortex. So adrenal cortex become, there is no hormone production. So there is no hormone stimulation. Adrenal cortex become hypertrophy. So this both adrenal cortex, adrenal is single organ or pair organ.
Okay.
Adrenal cortex, single or pair organ? Pair organ. Okay. So the one is when there is excess corticosteroid, due to an exogenous excess corticosteroid. Okay. Then this corticosteroid act on the anterior pituitary. So anterior pituitary produce less ACTH production. So this ACTH hormone act on adrenal cortex. It act on both adrenal gland. But now ACTH, no ACTH, so both adrenal gland become atrophy. So this is the cause. So suddenly the one that exogenous corticosteroid withdraw, like suddenly stop taking corticosteroid. The one in here, adrenal cortex is atrophy, right? Because of negative feedback. Then it leads to medical emergency, adrenal crisis. Okay, so this one I will explain again in ACTH hypercortisolism lecture, adrenal cortex lecture. Okay, but this one just for intro. So here you need to know is primary and secondary in here. Gonadotrophic hormone. So hypothalamus secrete gonadotrophin releasing hormone. And it acts on the anterior pituitary. Anterior pituitary produce gonadotrophin, FSH and LH. So this one just recall physiology. Okay. So graphene follicle cell, granulosa cell, estrogen and testosterone, corpus luteum, estrogen, progesterone, inhibin, testosterone. So whatever the one is, it produce gonadotrophin releasing hormone act on the anterior pituitary act on the ovary and testes to produce sex hormones. Okay. So abnormalities of gonadotrophin secretion. So this gonadotrophin and FSH-LH secretion abnormality leads to impaired secretion, leads to delayed puberty or hypogonadism, or present with premenopause, amenorrhea, and then infertility. And then premature release of gonadotrophin. Excess release of gonadotrophin leads to precocious puberty. Normally, puberty start at 13 years, right? So, but the puberty start 9 years or 8 years. When there is gonadotrophin abnormalities, the excess premature release of gonadotrophin, excess gonadotrophin release leads to precocious puberty. Growth hormone. Growth hormone is negative feedback as usual. Hypothalamus, there is growth hormone, releasing hormone, and growth hormone, inhibitory hormone. So this growth hormone act on the anterior pituitary. Anterior pituitary produce growth hormone. So this growth hormone act on the target tissue in liver. It produce somatomedian or insulin-like growth factor, anabolic. Okay, so this hormone act on this growth factor act on the bone, soft tissue, skin, and internal organ. Okay, so in here, the one I mentioned here, somatotropha, somatotropha. So the one anterior somatotropha, the anterior pituitary, they are cells, right? So the growth hormone producing the cells which produce growth hormone is known as somatotropha or somatotropha. So the one, the anterior pituitary, there is a tumor, benign tumor. Let's say benign tumor at the somatotrope adenoma. Then it produces more growth hormone production. Okay, if there is tumor, benign tumor in somatotropha, it produces growth hormone and produce more growth hormone and prolactin. So growth hormone deficiency leads to short stature. In children, it's short stature with normal. And then it is just now mentioned that it causes obesity and delayed puberty. Okay, at the lethargy, muscle weakness. Excess growth hormone before epiphyseal closure, it present with gigantism. After epiphyseal closure, present with acromegaly. So gigantism this is normal person. Okay, you see, compare with him, this is gigantism. Gigantism means increase in body size, disproportionate with long arm and leg. Okay, so this is gigantism. So gigantism is the one, the excess growth hormone that is before epiphyseal closure, then present with gigantism. That's why this gigantism, excess growth hormone is seen in occur in children. After excess growth hormone, after epiphyseal closure, when is epiphysis closed? Epiphyseal closure. When is epiphyseal closure? After this time, even you go to gym, you cannot tall. You know that the kids, children, they go to they do exercise and then because they want to grow, they want to be tall. So, but in one time, even you do exercise, you cannot be tall. In one time, in that age, even you do exercise, you play in gym, whatever, cannot tall again. Before that time, when you do exercise, when you eat, whatever, then you can be tall. It depends on the bone. Normally around 18 to 25 years. Okay, some 22 years, some say 22 years, some say 25 years, but depend on some bones close 18 years, some bone epiphysis close 22 years, some 25 years. But after 25 years, it's impossible to grow to be tall. Okay, so this excess growth hormone before epiphysis closure means like excess growth hormone during a children's life, not adult life, like 18 years, 17 years, 16 years, 14 years, when there is growth hormone, excess growth hormone, then it can cause gigantism. But after epiphyseal closure, it means that after 25, there is excess growth hormone due to tumor cause. They're present with acromegaly. Okay. So acromegaly is occur in acromegaly is growth. So here, why acromegaly? So in here you see the growth hormone act on the liver to produce somatomedian, insulin-like growth factor. So this insulin-like growth factor act on the bone, soft tissue, skin, internal organ. So before epiphysis closure, it act on the bone. So the person present with long gigantism, tall. Okay, and disproportionate of long arm and legs. But after epiphysis closure, after epiphysis closure, when there is excess growth hormone, cannot be torn, so the bone become thickened. Okay, soft tissue, skin, internal organ. So in here, acromegaly is excess growth hormone after epiphysis closure. It means it occur in adult. So when this excess hormone, growth hormone act on the skin and soft tissue, internal organ, visceral organ, and the bone. So there is the bone density is increase in bone density. Okay, especially in spine and hip. And then feature is ghost feature, enlarged here protruded jaw because of increased bone density, broaden lower face. So okay, and then it acts on the skin and soft tissue internal organ. So the one in here, the enlarged feet and hand, and then the thickened finger like sausage. Okay, this is normal one, this is abnormal. So this is normal person, this is acromegaly person. So acromegaly person, the hand is big, and hand is enlarged. Okay, fingers are also thickened. Sausage, you know sausage, it's thick. It's uh, fat. The others, it causes headache, sweating, diabetes mellitus. Growth hormone reduce blood glucose level or increase blood glucose level. Hey, answer. Cepat.
Increase, doctor.
Okay, so increased blood glucose level. So this increased blood glucose level leads to hyperglycemia leads to diabetes mellitus. Okay, and then it can cause hypertension. Hypertension can lead to heart failure. And then just now I mentioned that the growth hormone act on the bone, increase bone density, so it can cause arthritis and muscle weakness. And then there's endocrine organ can cause gonadal dysfunction. And then excess growth hormone, they have increased risk of GI tract cancers. Okay. Okay, so investigation of excess growth hormone. So when there is excess growth hormone, the excess growth hormone, insulin-like growth factor. So when there is growth hormone, increased blood glucose level. Okay, so the patient is now excess growth hormone. So when we give in normal condition, hyperglycemia, there is reduced growth hormone production. So the hyperglycemia condition, we do oral glucose tolerance test. But the growth hormone is still increased. Then it means there is excess growth hormone. I repeat again. So growth hormone, normal condition, growth hormone increase blood glucose level. Okay. So in hyperglycemia condition, there is reduced growth hormone production. So the hyperglycemia condition means oral glucose tolerance test. When we do oral glucose tolerance test, growth hormone is still increased. Supposedly it should be decreased, but it is still increased production. There is still excess. It means that the patient has excess growth hormone. Growth hormone deficiency, same as just now. So growth hormone increase glucose glucose producing. Increase blood glucose level, not glucose. So the insulin cause hypoglycemia. When there is hypoglycemia, there is excess growth hormone production. Okay, because growth hormone increase glucose level. So hypoglycemia with increased blood glucose level. So insulin cause hypoglycemia. So the one we give insulin to the patient, even growth hormone is insulin to the patient. So now supposedly when there is insulin, there is hypoglycemia, it leads to excess growth hormone production. But still growth hormone is deficiency. It means that this patient has growth hormone deficiency. And then after exercise there is excess growth hormone. But this patient has still growth hormone deficiency, reduced growth hormone. It means that this patient has growth hormone deficiency. Prolactin. So prolactin is prolactin releasing hormone. Hypothalamus produce prolactin releasing hormone and inhibitory hormone. So this hormone act on the anterior pituitary. The anterior pituitary, there is a lactotrope cell, mammo-somatotrope cell. So lactotrope cell produce prolactin, mammo-somatotrope cell. Mammo mean breast lah. So produce prolactin and somatotrope mean growth hormone. So this mammo-somatotrope cell produce prolactin and growth hormone. Okay, so this prolactin releasing hormone or inhibitory hormone act on the lactotrope cell and mammo-somatotrope cell in anterior pituitary. So depend on the releasing, if there is releasing hormone, more prolactin production. Inhibitory hormone, less prolactin secretion. So prolactin act on the mammary gland. The function of prolactin is milk secretion. Friend, prolactin is milk secretion. Prolactin deficiency leads to lactation failure, menstrual disorder, delayed puberty, infertility. Excess prolactin, galactorrhea, decreased libido, secondary amenorrhea, failure of ovulation, and infertility. Okay. So galactorrhea, normally milk produced when during breastfeeding, milk produced from the breast. But in galactorrhea there is no breastfeeding. Okay, no breastfeeding, but still milk production. This is called galactorrhea. Okay, lactation means during lactation, the baby after delivery, there is breastfeeding, right? So breastfeeding, because this is normal physiological process, breastfeeding, milk production from the breast. But galactorrhea means because of excess prolactin. So even there is no breastfeeding, there is no baby delivery, but the milk production. Okay. Okay, this one just summary lah. TRH, T3 thyroid produce T3, T4, adrenal cortex, corticosteroid. This one always confused. Adrenal cortex and adrenal medulla. Adrenal medulla is kata core amine. Cortex is CO lah or core. Yeah, corticosteroid. Okay, COR. Okay, and then gonadotrophin, FSH, LH act on the gonad organ, testes and ovary. Okay, so this growth hormone act on the bone and internal organ. Prolactin act on breast. Okay, this one just summary. Okay. Okay, oxytocin. So oxytocin is oxytocin causes cervical dilation in pregnancy, and it stimulates oxytocin release. So the oxytocin is the function is uterine smooth muscle contraction. So the one it's used in parturition. And then oxytocin act on the smooth muscle surrounding the lactiniferous duct. So it facilitates lactation. Just now I mentioned that prolactin. Prolactin is milk secretion. Milk ejaculation is oxytocin action. Okay, different. So oxytocin, smooth muscle, contract, act on the smooth muscle. So there is when baby suck, then oxytocin, then ejaculation. Milk contract the smooth muscle. Okay. So synthetic oxytocin, because this oxytocin, cervical dilation, smooth muscle, uterine smooth muscle contraction, so it can use in induction of labor. Normally it use low dose because the oxytocin side effect is can cause uterine rupture, because it said that smooth muscle contraction, right? So high dose, this smooth muscle contraction can lead to uterine rupture. So that's why I need to give low dose. Okay. Yeah. Okay, antidiuretic hormone. So antidiuretic hormone is, the function of antidiuretic hormone is water reabsorption in the collecting duct. So antidiuretic hormone deficiency it leads to diabetes insipidus. So water reabsorption in the collecting duct impact water reabsorption. So it leads to polyuria. Polyuria causes dehydration. And then when in the blood there is the loss of urine loss, fluid loss and urine, polyuria. So in the blood there is sodium and osmotically active substance, they become increased. So plasma sodium level is increased. So this increased plasma sodium level, increased osmolarity, stimulate the thirst brain. So it stimulates the center, so it causes thirst and it leads to polydipsia. Okay, so this polyuria, polydipsia is like diabetes mellitus symptoms. So it is called diabetes insipidus. Diabetes mellitus, the cause is hyperglycemia due to insulin deficiency or insulin resistance. But in diabetes mellitus, is due to antidiuretic hormone deficiency. Why it is similar? Because in diabetes mellitus, there is hyperglycemia due to insulin deficiency or insulin resistance. So this hyperglycemia leads to increased glucose level in the blood. So this increased glucose, normally glucose can normally cannot pass to the glomerulus, but this hyperglycemia increase blood renal threshold level, then this glucose pass into the urine. It leads to it leads to glycosuria. So glucose pass into the urine. So glucose is a osmotically active substance. So it absorb, it attract water. So it leads to polyuria. Okay, so and then in the blood, the glucose is osmotically active substance. So this glucose activate the third center, and then it leads to, and then there is water shift from the high hydrostatic pressure, high osmotic pressure to low osmotic pressure. So from low osmotic pressure to high osmotic pressure. So just now blood glucose is high in the blood. It means that high osmotic pressure in the blood. So the fluid, intracellular fluid, is low osmotic pressure. So the fluid shift from the low to high. And then it also stimulates the third center, so it leads to polydipsia. It's okay. Diabetes mellitus, today Dr. May will teach you. Give lecture. Okay. For why diabetes mellitus and insipidus same, because the same mean diabetes, why you see here because of polyuria and polydipsia. So in antidiuretic hormone deficiency leads to diabetes insipidus, because antidiuretic hormone is the water reabsorption when at the collecting duct. So antidiuretic hormone deficiency, there is no water reabsorption. So it leads to polyuria. So polyuria, in the blood there is increased plasma sodium level. So this increased plasma sodium is increased osmotic pressure. So it leads to activate the third center. So third center leads polydipsia. So causes of diabetes insipidus. Okay, head trauma, tumor, inflammation, surgery, and then cranial okay, there are two types of diabetes insipidus: cranial diabetes insipidus and neurogenic diabetes insipidus. So cranial diabetes insipidus is antidiuretic hormone deficiency. Neurogenic diabetes insipidus is collecting duct is resistant to antidiuretic hormone. Okay, now after this, there is a lecture of parathyroid hormone disorder. So when the hyperparathyroidism, there is gasification, parathyroid increased calcium level, right? So the hyperparathyroidism, there is increased plasma calcium level. So this calcium deposition in renal tubules. So these renal tubules resistant the antidiuretic hormone. This condition is called nephrogenic diabetes insipidus. Okay, so diabetes insipidus, there are two types. To the antidiuretic hormone deficiency, no antidiuretic hormone production is cranial diabetes insipidus. Antidiuretic hormone is present in the blood, but the collecting duct is resistant to antidiuretic hormone. It is called nephrogenic diabetes insipidus. It is seen in hyperthyroidism. as hyperparathyroidism. Okay. Excess is antidiuretic hormone. So antidiuretic hormone is just so excess. Then there is no water, is no urine output, right? So the one urine, the fluid is accumulate is there is excess blood volume. It means the water reabsorption. So this water reabsorption leads to dilutional hyponatremia. So sodium level, low sodium level. Sodium level is normal because of excess, because of water retention. This is called dilutional hyponatremia. Let's say like in the cup, you put 1 cup of water. Okay, so this is a cup. Okay, 2 cup. Okay, you put the water, 1 water cup here, water, and then here water, desiccate. So you put 1 spoon of salt, okay, in 3 water. So in here, this is normal. The space and then the taste different because this is banyak water, right? So this leads to dilutional hyponatremia. In the blood, sodium amount is normal because of water reabsorption, water retention here. Then the sodium become dilutional hyponatremia. Sodium level is low because of dilution, water retention, because of antidiuretic hormone excess. So function of antidiuretic hormone is water retention, right? So the one there is excess water retention, it leads to dilutional hyponatremia. So nausea, anorexia, weakness, headache, these are the clinical manifestation of dilutional hyponatremia. Okay, causes of SIADH is CNS disorder, antidiuretic hormone secreting pituitary tumor, small cell carcinoma, and then drugs that increase antidiuretic hormone. So here hypothalamus and so hypothalamus, the supraoptic nucleus, it produces antidiuretic hormone. So this antidiuretic hormone, posterior pituitary is a posterior pituitary is synthesized in the nerve cell in the hypothalamic nucleus. So they want these antidiuretic hormone oxytocin, they synthesize in hypothalamus and secrete in the store in the posterior pituitary. So when there is a disorder, antidiuretic hormone disorder, oxytocin disorder, normally it is associated with hypothalamus. Okay. So anterior pituitary adenoma. So anterior pituitary adenoma is the most common cause of hyperpituitarism. Common in adult, it can secrete 1 or more hormone. So classification is based on the hormone production and the base of the site of adenoma. So hormone production, SIZE size. Not SIZE here. Okay, size and hormone production. So hormone production is function is just now I mentioned that if there is excess hormone production, it is called functioning pituitary adenoma. So it means to hyperpituitarism. If the pituitary adenoma is at the corticotrophs cell, it produces excess ACTH and pro-opiomelanocortin. So this melanocortin act on melanocyte, so it leads to it produce melanin. So this melanin leads to hyperpigmentation. Thyrotrope adenoma, it produce excess DSH, lactotrope, prolactin, somatotrope, memosomatotrope, gonadotrope. Okay, so when there is adenoma, they produce hormone. Non-functioning adenoma means there is tumor, but it just press on the adjacent tissue. So, but this tumor, it doesn't produce hormone, but it press on the adjacent normal endocrine organ. So it leads to hypopituitarism. Okay, hormone, the tumor itself doesn't produce hormone, and additionally, this tumor press on the normal adjacent pituitary gland. So this normal pituitary gland cannot produce hormone because of pressure effect. Okay, so it leads to hypopituitarism. Functioning means pituitary adenoma, the tumor itself, it produces more hormone. It is called functioning. So it leads to hyperpituitarism. Size. Size is depend on the size. Microadenoma means the size is less than 1 centimeter. It is called microadenoma. Macroadenoma is more than 1 centimeter. It is called macroadenoma. Normally, macroadenoma, they are non-functioning adenoma. And then it compresses the adjacent normal tissue. And it leads to hypopituitarism. Here, you see this is pituitary adenoma. This pituitary adenoma press on the normal adjacent tissue. So normal adjacent tissue become atrophy. It leads to hypopituitarism. Okay, this is pituitary. So pituitary act on the adjacent normal tissue, and then it leads to hypopituitarism. Okay, and then here this is brain. So brain is in the confined space, right? It is covered by skull. So when there is tumor, then it increase intracranial pressure. Okay, clinical cause. So the clinical features are related to endocrine abnormalities and tumor effect. So just now, increased ACTH depend on the tumor. Adenoma, corticotrope adenoma, increased ACTH. So Cushing syndrome, hyperpigmentation because of egg on the melanocyte, increased melanin production. Pyrotrope, increased TSH production, it leads to secondary hyperthyroidism. Lactotrope, excess prolactin, so the clinical features of excess prolactin. Somatotrope, the excess growth hormone depend on the epiphyseal closure. Before epiphyseal closure, present with gigantism. After epiphyseal closure, present with acromegaly. Mostly gonadotrope adenoma, they will reduce FSH and LH level. So this is exception. Mostly the one it leads to hypogonadism. Okay. So just now you see that this is pituitary tumor. Okay, so it compresses the adjacent tissue. And then pituitary anatomy. So anatomy, this is pituitary gland, this is optic chiasma. Okay, so this is pituitary, and then this is sphenoid bowl, and there is a optic chiasma. Okay, so optic chiasma, when this pituitary gland is enlarged, it compresses the optic chiasma. So optic chiasma is supply the eye. So there is a visual field defect. And then here, this is mass tumor effect. And then this pituitary gland, when there is tumor means enlarged, right? So this is stellar testicle bone. So it compresses the stellar testicle bone. And then it compresses the stellar testicle bone, it compresses the optic chiasma. Okay. So compress the optic chiasma cause visual field defect. And then just now mentioned that here, this is pituitary gland. This is brain. So the one when it enlarged, this brain is in the confined space. So it leads to intracranial pressure. Okay. So tumor effect, one is small, first compress the optic chiasma. If big, it increase intracranial pressure. So intracranial pressure present with headache, nausea, vomiting. Or this tumor suddenly increase in size, then it leads to hemorrhage. So this hemorrhage can cause sudden death. Okay, neurosurgical emergency. So investigation is your adenoma, mass effect, visual field testing, or the CT MRI. Okay, in X-ray, the stellar testicle bone expansion or erosion. Okay, causes of hypopituitarism. So pituitary congenital is rare, acquired is destructive cause, non-functioning adenoma, cancer, cyst, inflammation, infection. This one just recall general pathology because, and then this tuberculosis, syphilis, this one you already study in microbiology, right? And trauma, surgery, radiation, ischemia. Okay, Sheehan syndrome. So Sheehan syndrome is after delivery, there is a postpartum necrosis after delivery, anterior pituitary necrosis, because of reduced blood supply. When after delivery, there is blood loss, postpartum bleeding, excess bleeding from postpartum bleeding. Then it reduced blood supply to anterior pituitary. When there is reduced blood supply to anterior pituitary, the anterior pituitary become necrosis. It is called Sheehan syndrome, postpartum necrosis of anterior pituitary. Okay, because of excess blood loss from during delivery. Okay. Hypothalamus causes tumor, radiation, infection, inflammation can cause a pituitary disorder. So 75% of 75% of parenchyma is lost, then present with hypofunction of anterior pituitary, 75% loss. And then hypopituitarism plus posterior pituitary dysfunction, it is always due to hypothalamic cause. Just now I mentioned that the oxytocin, antidiuretic hormone, they synthesize in the hypothalamus and then store in the posterior pituitary. So this posterior pituitary dysfunction, it is due to hypothalamus cause. Okay, and then the anterior pituitary. So the sequence sometimes after radiation therapy, the one we need to measure, we need to assess whether it affects on this radiation has side effect on the pituitary. So need to check growth hormone. So the growth hormone is the earliest to be lost. So if the one patient has brain tumor, then give radiation therapy. This radiation therapy, there is side effect, right? So it affects on it destructs the pituitary. How we measure? We check the growth hormone secretion, because growth hormone is the earliest hormone to be lost, and then followed by gonadotropin, ACTH, and TSH. If growth hormone secretion is lost, then it may be this radiation effect on the anterior and on the pituitary. Okay, so anterior pituitary hypofunction is depend on that hormone deficiency. Which hormone deficiency? That hormone deficiency is present with clinical manifestation. So hyperpituitarism, this normally hypopituitarism, melanocyte stimulating hormone is reduced, so patient present with pallor. Okay, because this ACTH, they are the same precursor. Okay, causes of hypopituitarism. So pituitary cause, this one already mentioned, huh? Okay. I repeat. So any question? Finish early. Any question? "45 minutes.
Doctor,
Mm.
Doctor, can you repeat again the Sheehan?
Sorry?
Can you please repeat the Sheehan syndrome?
Sheehan syndrome. Okay, Sheehan syndrome is anterior after delivery, there is blood loss from the bad gunner, right? The one from the placenta separation, there is blood loss. So there is sometimes the patient has during the delivery, there is excess blood loss. It means postpartum hemorrhage. Okay, excess blood loss. Then there is reduced blood supply to organ. In brain, there is reduced blood supply to anterior pituitary, because anterior pituitary is supplied by blood, right? So this anterior pituitary reduced blood supply to anterior pituitary. So this anterior pituitary cause necrosis. So this is called postpartum necrosis. Like pregnant woman, that woman has after delivery, there is postpartum hemorrhage, excess postpartum hemorrhage, excess bleeding after delivery. Then there is reduced blood supply to the brain. So the one in the anterior, not only brain, everywhere there is reduced blood supply. So in the brain, there is reduced blood supply to anterior pituitary. It leads to necrosis, pituitary necrosis. This is called Sheehan syndrome. So when there is anterior pituitary necrosis, the patient, the mother cannot breastfeed because there is no prolactin secretion. So it cannot breastfeed because of prolactin deficiency. Okay. It leads to lactation failure. Is it, and can you understand? Faham or need to explain?
Understand, doctor.
Okay, any question?
Doctor,
Yeah.
can you explain about investigation of growth hormone deficiency?
Okay. Okay, normal function is growth hormone. Its function is glucose release, okay, excess glucose. So the one in patient hyperglycemia, then growth hormone is hyperglycemia, there is reduced growth hormone production. This is normal physiological process, right? In hyperglycemia, there is reduced growth hormone production. So now the patient has excess growth hormone. So we need to measure this excess growth hormone is due to tumor, due to environmental cause, due to other causes, or because of this anterior pituitary cause. So the condition is hyperglycemia cause reduced growth hormone. So it leads to do oral glucose tolerance test. So oral glucose tolerance test cause means hyperglycemia. So if oral glucose tolerance test, growth hormone must be reduced. But it is still increased. It means that it cannot suppress growth hormone production. It is still increased growth hormone production. It means that this excess growth hormone is because of anterior pituitary cause, not because of other conditions. Okay. It's same like growth hormone deficiency. So growth hormone release glucose. So insulin, hypoglycemia, increase growth hormone production. So how to do hypoglycemia? Insulin reduce insulin cause hypoglycemia. So hypoglycemia increase growth hormone production. So we need to detect if growth hormone, now the patient has growth hormone deficiency. So this growth hormone deficiency is due to hyperglycemia cause or due to other condition or due to anterior pituitary cause. So how to do the insulin tolerance test? So patient give insulin to patient. So supposedly when there is insulin, when the patient take insulin, then it must be the insulin cause hypoglycemia, so it must be excess growth hormone again. But the patient still growth hormone level is still low, then it means that the pathology is not the other condition. Pathology is because of this anterior pituitary.
Okay, thank you, doctor. Understood. Understood, doctor. Thank you.
Any question? Any question? If no question, then I stop the for today class. It's okay. If you don't understand, as usual, you can ask me anytime. Just send me WhatsApp. Ask me in WhatsApp. Don't send message in Telegram. I only use the Telegram for upload the post. I don't read the message because there are many message. Even the under also there are many message. Okay, so just send me